Welcome to this session on the Dementia UK Summer School. I'm sorry I won't be with you on the day. I'm talking elsewhere, but I know my colleagues from Dementia UK will happily pick up any further questions. So this session, I hope you're going to find it useful. It's on health and lifestyle risk factors and dementia. Now, forgive me if you keep seeing me looking over that way, but I've got two screens here, slider on one and the camera's on the other. So bear with me if you see the side of my head. So we're going to talk about health and lifestyle risk factors and dementia. And my name is, for those of you who don't know me, some of you may have seen me at previous summer schools. My name is Chris. I'm an Admiral nurse, and I also work as an associate professor in neurocognitive and neurodevelopmental studies at De Montfort University in Leicester. And I mostly teach nurses, paramedics, social workers about dementia and other conditions too. So thank you for joining me today. I'll go through the slides one at a time. I can't say stop me if you have any questions because you're not going to be there, but there will be an opportunity if you have questions to ask my colleagues on the day itself. What I'll do where possible is try to take it slowly and give you some pause for reflection. So I hope it's going to be useful. And then on the day, you can add some of those points of reflection in the comments box as needed. And then my colleagues can pick up on those areas on the day itself. So we'll make a start if that's okay. So I'll move on to the next slide. And I guess this is really starting to talk about the whole idea about having risk factors. And if we have risk factors, we can start looking at risk reduction. And the whole idea is dementia preventable? Now, I would argue it's not preventable, but we can reduce the risk. And for my colleagues out there who are listening in, falls is a great example of saying that. We've stopped saying fall prevention, we say fall risk reduction. And the same sort of idea we can apply in the field of dementia. So I've got three really important reports here, and they're all been done by the same person who led it, Livingston. And these reports are a collection of all the research out there at the time of publication as to what did they find from the research was potentially a big causative factor of dementia and potentially something we can do something about. And we call that modifiable. So to modify, to change, a modifiable risk factor. So back in 2017, there were 9. In 2020, not so long ago, there were 12. They added 3 more. And then more recently, only last year in the summer, I think it was June, 14, 2 new factors were added. To those of you, if you're in the group and you're listening in and you're doing training sessions or public health, it's important to highlight to students there's been an additional 2 added. So now there are 14 evidence-based dementia risk reduction factors that we can start to talk about. And as we go through the session today, I'll be asking you to wonder and reflect, is that a risk reduction factor that's relevant to you or to someone you know? I would argue we can't do them all, but there may be some we can tackle. So that's what we're going to look at. And what these authors said, and particularly in this newest update in 2024, if we address these factors, then potentially 45% of dementia cases globally can be reduced. In 2020, it was 40%, and now it's 45%. So the more we know about dementia risk reduction factors, potentially we can reduce the risk of people being diagnosed. So that's the importance and the idea. Now you can see I put a lot of emphasis on the work of Livingston. So in a minute, I'll show you the key reference. But before that, an important note. Having one of the 14 risk factors we're going to start talking about does not mean you'll get dementia. So I don't want you to panic. What it does mean is if you have one of these, it puts you at an increased risk. So the idea is look at the 14. When I show you the slide, that's on slide 5. Look at the 14 and just think which one of those could you start to tackle. And when we're doing this in a practical way, It may not be appropriate to address them all at once. There may be a couple that you feel happy to change or adapt, and you gradually build up on it. But if you know what the 14 are, you can start making appropriate choices to see what you can tackle. But I don't want you to panic if you think you have one of those risk factors, because it doesn't mean you will get it, but it does mean it's something that may increase your risk. So just have a little think about what you can do if that's possible. We can also start thinking about how the risk may be accelerated if you have multiple of these areas. So just by addressing one, you are going to be reducing your risk as much as you can. So put that there. Some of these are modifiable, you can change, and others you may see there's at least a couple on there which may not be so easy to modify, but I'll talk more about that when I get to it. And then at the end of the slides, there's a short overview or a little discussion about non-modifiable risk factors. So things that we can't change. So you may look at the original list of 14 and think, hang on, I thought the biggest risk of dementia was age, and that's not the 14. And you're right, it's not, because we can't change our age. But there is a check-in at the very end where we do look at some of the other more common risk factors, but we may not be able to change those. So I hope that makes sense. 14 risk factors. We'll think about what we can change. You must not panic if you've got those. What we need to do is think carefully, how can we plan to address those, and what's reasonable given our context. Now, I said these came from a piece of research done by Livingston. And here we are. I've highlighted it in bold yellow because it's really important we give credit to the work of Livingston and her colleagues in developing this guidance, which appeared in the Lancet. So again, those of you who are involved in education or policy development or changing practice, it's really an important document to have. Be careful when you press print. I've got one in front of me. It's lots of pages, but it's a really important document to have, and you can get it quite easily on the internet. It's not restricted, which is nice. So the Livingston G et al. 2024, Dementia Prevention, Intervention and Care. And what I'm going to be focusing on is the first part of that document, which talks about prevention, although I would rather use the word risk reduction. So I hope that makes sense, and Google that as you see fit after you've listened to this session. So I've said there's 14 risk factors, and here they are all together. And I've done a slide on each of those. Not all the slides are in detail, because some are quite self-explanatory, and some of the research that underpins it is just a big discourse about how many trials were carried out, how do they know it was accurate, etc. We call that validity and reliability. And that's what the authors did to make sure they were talking about appropriate elements. So some slides are quite short, so don't worry. I won't have you here for too long going over lots of details. But here are the 14. You'll see I've put the 2 new factors are shown in bold, and that's at the very end of column 2. So I'll say what they are. Education, particularly in early life, but also we're starting to see about the importance of doing education and cognitive stimulation in midlife too. The risk of social isolation, air pollution, traumatic brain injury, sometimes called TBI, hearing loss, depression, high blood pressure, sometimes called hypertension, diabetes, obesity, physical inactivity, smoking, excessive alcohol consumption, and the 2 new ones since 2024, uncorrected vision loss and high cholesterol, particularly LDL. More on that later on. So those are the 14 risk factors we're going to have a quick look at. But before I do, I just want to give you a minute. And if you're listening to this live, if in the comments box, you can pick 1 or 2 of those that you think, I get the idea of having to reduce our risk, but some of those are impossible to do. I have no control over. So although we can say these are modifiable, because they are, socioeconomically or due to our life circumstances, it actually may be something we can't do anything about. So if there's anything on that list you think is not modifiable based on various social or economic circumstances, do you want to just drop that in the comments box now? I'll just give you a few seconds. So which one of those do you think is a risk factor that is less likely to be modifiable, usually based on socio or economic challenges or family reasons, etc.? Okay, thank you very much. I'll let my colleagues pick up on what you've written in the box on the day itself. So I shan't give any clues right now because it's up to you what you think is there. So taking the first one, education. There's quite a bit on this slide because there's so many important elements I want to just to highlight. What the report actually discussed was the quality of early childhood education. Now we can think about it in various different ways. What do we mean by a quality education and what do we mean by an education? It's not necessarily a formal system of you've gone to nursery and you've learnt this, you've gone to primary school and you've done this. Education can manifest in very different ways. And we've got to remember that this whole report was done globally, not just based on Western countries. And what we see as education may not be seen in a different country or in a different way of upbringing children. But it's about those teaching practices, the learning that's happening, the idea that the brain itself of a child is thinking about things in a new way and developing new circuits, brain cell connections, etc. Doesn't have to be a formalized exam or test. We learn all the time. So I want you to think about this as a way of early experiences that are challenging the brain, that actually makes the brain make new connections. And I put there, as we learn, brain cells make new connections, and we can call that circuits. So as we produce these circuits, we're building up more brain power. And what it actually does is it gives us a stronger resilience if things go wrong. Now, the proper term for this is cognitive reserve. When I talk to my students, I may call it brain backup. It's like having some something in reserve, brain backup. If something goes wrong, you've got something else that you can use in its place. And all this refers to is the brain's ability to withstand neuropathology. That means if something goes wrong in the brain, you've got additional brain cells to sort it all out to compensate for any loss. That's the idea. And what we do know is if you have these things in place, you have naturally built up this cognitive reserve from an early age. And that's really important to do. So it's not just about formal education. It's about working with kids, playing with kids, giving them new experiences, taking them to different places, questioning. There's a whole array of different things we need to do. Don't think you need to put your kids in nursery to do this. You don't. You can have great fun. We've got a 4-year-old niece and she goes to the zoo and there's all sorts of questions. That's new and early experiences increasing the circuit pathway in the brain. I do Makaton, a form of sign language. So what I do with her is when we're babysitting, etc., is I'll talk to her about the foods and she's got to sign it to me. So I show her what the sign is. She's got to say the food and sign it back. And not only is she learning sign language at the same time, I'm also helping her build extra circuits in the brain. So there's little things we can do. You may look at, if you're bilingual, teaching a child a new language or learn a language with your child. There's many things we can do. So the other element is in an early education, depending what we're teaching as well, we're also helping people understand the importance of how we have a healthier life and what is healthy, what's not healthy. Particularly sometimes when we talk to young people, their knowledge about a healthy lifestyle seems a bit odd for some people. So it's making sure what they've got are clear facts as to a healthy life. And there's a growing area of work that midlife education, particularly cognitive activity, can make a huge difference. So if you've not had a strong early education, there's a degree of work we can do now in midlife to still develop some more cognitive reserve or brain backup. And I know when I worked as a dementia care nurse in a day hospital, lots of the activities I would do with people who had a diagnosis of dementia would be to still support some degree of cognitive reserve build-up using what they've got still, and helping them to make new connections. And I used to argue quite clearly that roles like the activity provider, meaningful activities, etc., are really, really important functions to be carried out in care settings and at home, because you can still help people bring this idea of circuit making to the fore. So pause for a second. I'll let you read that little slide. Lovely. So if that's okay, I'll move on to slide 2. Social isolation. There's a growing body of evidence that being lonely and not socially connected is becoming a very large factor in the risk of dementia. And initially, that's when it first came out quite a few years ago, that was a surprise to me. But it's interesting when you think about why that can be the case. It's often some of these connective pathways. So social contact builds cognitive reserve, what we've just discussed. So if you isolate, you may be less likely to. But also social isolation can have a knock-on effect in some of the other risk factors that we saw in the previous slide, like smoking, health conditions like high blood pressure, etc. So there's a growing body of evidence to say the more we keep connected socially, the more we may reduce our risk. Now, for some people, that may be a struggle out of choice. I've got autism, so sometimes I may not want to interact, but I know if I do, I've got opportunities to do so. So the process here is, are we providing opportunities for when people want to increase their social contact? And just looking out for people that are not socially isolated, not by choice. 3, air pollution. Now, this may be one of the things you put in your comments box with a, yeah, that's something I can't control because this is where I live, or this is where I work, and I can't afford to move elsewhere, or this is where my family is, or the school, etc. So this could be one of the things in your comments box. Growing body of evidence, air pollutants, the tiny particles or gases in the air, exhaust fumes from traffic and cars, etc. The evidence here is starting to say that these air pollutants are actually damaging blood vessels and can lead to heart disease and poor blood supply. There's also evidence that talks about, particularly car exhaust fumes, how they actually affect the brain's ability to remove amyloids in the brain, increasing buildup. And those of you who know a bit about the neuropathology of the dementias, including, for example, Alzheimer's disease, there's a big talk about the amyloids in the brain in the hippocampus and how that may lead to Alzheimer's disease. So this growing body of evidence talking about the risks of air pollutants and how it affects us cardiovascularly, vascular dementia, and also brain and our amyloid proteins, Alzheimer's disease. So more research is needed actually on which particular matter constitutes are more problematic. So that 0 at the end is meant to be an end paragraph, so forgive me about that. But whether there's more thing about sulfates, nitrates, black carbon, what is it that's got having the biggest effect? So we're still researching this. And then I've just put these 2 questions here, which you may want to answer in the comments box. Do you think some occupations are more at risk of air pollution than others? And are there some places to live which put you at greater risk? So either question 1 or 2, do you know of any particular occupations where people are likely to be more exposed to air pollution, or are there any places to live which put you at a greater risk of air pollution? If so, do you want to just pop them in the comments box? because we all can see that, and that way we get a greater idea of what's out there. It could be something we've not thought about. I'll just give you a moment. Okay, so I'm sure today Maggie or one of my colleagues will have a look at that comments box and share some of those points with you. Just in case it's not down there, I don't know if there's anyone on the call today who knows of. I'm going to give an example, and there's no research on this. This is just an example from my head as I'm talking out loud. Fire crews, because if they're coming into contact with burning buildings and things, wildfires, etc., then what's being burnt off, could that be an air pollutant, or does the mask that they wear save them from that? Again, I don't know. It's just something that occurred to me as I was talking, only because where I live, we've had sadly last week there was a big fire on Barden Hill. Anyone who knows Leicestershire, and that raised a lot of pollutants in the air and so on. So it's a thinking point, isn't it? Occupations, but also where you live. TBI, traumatic brain injury. It can be mild, moderate, severe. And the bit I wanted to highlight here is some sports can actually increase the risk. And this may be something that you've heard of already. So repeated blows to the head, we used to call that dementia pugilistica. Pugilism is Latin for boxing. So you can imagine in the past where boxing led to repeated blows to the head, dementia pugilistica, that's where that term comes from. So some sports like boxing, football, rugby, so high contact sports, etc. So in football, in their report, they do look at quite a few studies which looks at the risk of dementia in footballers, something I think has been on the news quite a bit, certainly last year. The lowest risk in footballers was goalkeepers. The highest risk in footballers were defenders, because they're the people most likely to be heading the ball. So something to be aware of. It's not footballers, it's the footballers who are more likely to be heading the ball seem to be the footballers who are at greater risk of getting dementia. And of course, there's other sports as well, with the high contact sports like boxing and rugby. So it can cause or exacerbate dementia as a result of a direct trauma. Now, what I do want to say is sport is good for health, and we can see actually sport and physical activity is a protective factor. But we must ensure that we're using appropriate protective wear. People who are supporting football practice and coaching, that if you're going to be practicing heading or headers, you're doing it limited, you're not doing it consistently, because that could be problematic. So that's TBI. So again, in the comments box, if you just make a quick note, can you think of any particular sports? And it may not be sports. Sports is all I can think of. Any sports where you think there's a higher risk of this repeated contact or direct trauma to the head? We've mentioned a few, but is there anything else you can think of? Or any other circumstance you think people could face in their lives where they've got this continued trauma? I'll let you have a little think and jot some things down in the comments box as you see fit. I guess the other bit, while you're writing that down, is it's okay to say appropriate protective wear, but what if protective wear isn't being provided? Is this something we ask for? So students at university, when they're joining the clubs and societies, etc., oh, I'll do this. Do they check what protective gear is out there, and how do people feel? If you were the lad, you're playing rugby, but oh no, I want to wear one of those protective head, I don't know what they're called, head helmets, but no one else is. Would you feel, oh no, I'm going to feel silly wearing this, I'm not going to? There's a whole range here about social circumstances, resource circumstances, psychological circumstances, which could mean protective wear is available but not being used. So that's a whole different dynamic of a study as to work out why. And I wonder whether if we increase protective headwear in primary school to secondary school that then when we were using it in sports and university and college and adult teams, it becomes normalized. It's not something seen as being odd. So that would be my aim, that we introduce protectiveness in primary school and we sort of build on it so it becomes normalized. Next, 5, hearing loss. So there's two main types of hearing loss, peripheral and central. One is where the ears don't pick up the sound, so we tend to use hearing aids. And the other one is central hearing loss, where hearing aids may not be as effective because it's a problem with the brain processing rather than being able to hear. And about 20% of people globally that we know of tend to experience hearing loss. So we're not quite sure why, but it's a very interesting factor that we find people with hearing loss are more likely to or have a high risk of developing dementia. So I put here, does the use of hearing aids in people with hearing loss eliminate or mitigate dementia risk? And what I mean by that is, does using a hearing aid mean you're at lesser risk of social isolation or taking part in educational stimulating activities? Because you've got your senses, you're more likely to engage. And therefore, that's why if you are using your hearing aids, if you have no hearing loss, you're more likely not to experience additional factors. Whereas if you do have hearing loss, but you choose not to wear your hearing aid, does that mean you're more likely to socially isolate yourself, etc.? So what we do know is hearing loss, if we call it treating hearing loss, if we treat hearing loss, you reduce your dementia risk. So if you have hearing aids, put them in, because the idea is you're more likely then to engage. And if you're more likely to engage, then you're reducing your risk based on other factors like social isolation and cognitive processing. Depression. So there's quite a few mental health conditions, whether it's functional or emotional. And for ones looked at in the report, it ranged from depression, anxiety, bipolar, schizophrenia. And there's some very interesting debates in the document, in the report itself, if you wish to read that. But one that they found there was a good amount of evidence for was depression. It does talk about the other mental health conditions, so it's worth a read. It's just there wasn't a lot of information yet. But if we focus on depression, is depression a symptom of dementia or a risk factor for dementia? And you could argue it's a bit of both. And that's why we are still discussing at what point is depression an issue in dementia. The research does suggest that depression does increase the risk of dementia in all adult ages. And again, we can link it back to the social isolation as a factor. And as some of you know, I don't know if there's any mental health nurses, etc., on the call, but it could be that you may be aware that people who are depressed are likely to have a poor diet or may not even eat. They may have some very clear withdrawal symptoms, including not eating. So is that what's causing the increased risk? So is it depression itself, or is it the effects of depression? Now, there is some growing evidence that depression itself may have an impact, because depression can be linked to stress. And we may or may not know, I'm not sure about your backgrounds in the room, but you may or may not know that stress increases your level of cortisol, which some people call the stress hormone. And what we do know is over-secretion of cortisol for a long period of time can have a negative effect on the hippocampus. Now, the hippocampus, I mentioned it earlier, and forgive me for all these big names, but hippocampus is part of the temporal lobe in the brain on the side. And that's normally affected, the first area to be affected in Alzheimer's disease. It's the hippocampus that controls orientation, short-term memory, etc. And that's where some of those amyloids are that we referred to earlier on. So continued oversecretion of cortisol over a long period of time can actually affect hippocampal function. So that's one of the, we can call it organic rationales for depression. And the other one, we can call it more like a reactive. You're reacting more to the experience of depression, which is making you less likely to work alongside others or take part in educational programs or eat not as well. So I guess it's a combination of both of those, which is why they've made that a risk factor. Next, high blood pressure. And this is one of the, you'll find I put a cardiovascular factor over some of these. There's quite a few cardiovascular factors. So there may be nurses and doctors here, I don't know, but you tend to have two numbers, systolic and diastolic. The way to remember that is diastolic, D. D's for the bottom bit, it's down. So you've got a top number and a bottom number. One is when the heart is pumping, and the other one is that little bit at the back, a little bit left behind when it's pausing, and the heart's refilling up. Then it pushes it out, then it refills. So you've got those two numbers. And what we do know is a continued high, the systolic one, the top number, if that's continued to be high for a period of time, then that can increase your risk. What the research does find out is people who are diagnosed with high blood pressure, who took the medication as prescribed, the hypertensive medication, were at a lower risk than people who had high blood pressure but didn't take the medication. So there's this growing evidence that having a high blood pressure will increase your risk. There's a small bit of evidence that starts talking about a sudden lowering of your BP as we age could actually be a warning sign. So be vigilant for that. Just be aware, as we age anyway, our BP tends to lower, and that's normal. But if there's a sudden lowering, it will be something to bring up with your GP to discuss. Another cardiovascular factor, diabetes. My students will tell me off here because I always tell them when you use the word diabetes, be clear to say diabetes mellitus or diabetes insipidus. Here we're talking about diabetes mellitus, the sugar one. So diabetes can be linked to other risk factors like high blood pressure, obesity, cholesterol. And some of the evidence is nerve cells in the brain may become resistant to insulin, leading to, again, this buildup of amyloid. But research is not as complete as it could be. And I remember years ago, we used to try and, there's not much discussion about this now, but we used to talk about diabetes type 3, which is this buildup in the brain. And people used to call it the sugar Alzheimer's. So you may have heard of diabetes type 1 and type 2. There was in the past a big discussion about type 3 based on this. But I've seen less and less discussed about that of late. But just out of interest, in the comments box, if you've heard of diabetes type 3, the Alzheimer diabetes connection, just put a Y for a yes in the comments box, just so that my colleagues on the day can get a flavour of whether this is something that's being talked about in the area or whether this is something that's slowly being moved away. So just stick a Y if you've heard of diabetes type 3 and the link between diabetes and Alzheimer's disease or dementia. Number 9, obesity. Particularly if you're obese between the ages of 35 and 65, the argument is, or the research that they found was, your risk of dementia increases almost threefold. And that could be the link to diabetes, high blood pressure, and the LDL cholesterol. There's also that link that if you are obese, are you more likely to face stress and stigma due to, and because of that, how you perceive yourself or you think others perceive you, is that going to increase cortisol, which, as we've discussed already, can cause some problems. Just as a heads up, just be mindful about deciding you're obese because of the BMI. The BMI doesn't measure really obesity. It measures how heavy you are compared to how tall you are. So some rugby players, huge mega units of people they are, they're not obese, but according to a BMI they would be. So just be very clear before you decide you're obese, please go and talk to a medical professional and get yourself measured and checked out appropriately, and do what you can to reduce obesity. Physical inactivity. Linked with the factors, and we discussed already things like depression, obesity, diabetes. We're starting to talk more about cholesterol, so I think that's going to come up relatively soon. And when I use this term, maybe bi-directional, that could be, is physical inactivity increasing your risk of dementia? Or is dementia increasing your risk of physical inactivity? Which way round is it? And bi-directional means it could be one or the other. And I guess depending on the different person. So just be mindful, one can lead to the other and vice versa. That's what we mean by the term bi-directional. What we do know, however, is exercise at any age is helpful for cognition. And I put here increases blood flow, enhances brain plasticity, which means your brain becomes more flexible to take on new ideas. This whole idea about cognitive reserve and learn new things, increase your circuits, etc. But also a growing body of evidence talking about neuroinflammation. So how do we reduce inflammation in the brain? And that's definitely a growing area of research in dementia, brain inflammation. And then this interesting bit about animals, they call them mice models. A lot of research on dementia has been piloted on mice before we look at what happens in a human brain. For various reasons, they are effective models to look at from a biological perspective. Anyway, I don't know if anyone here in the group has heard of a hormone, irisin, and that's secreted by muscles during exercise. And what the mice model research shows is irisin has a potential neuroinflammatory effect on the brain. So it's a protective factor. If we think there's this risk of inflammation, well, irisin reduces neuroinflammation. So is that one of the biological reasons why physical activity can be useful? So we've got the cardiovascular support. We've also actually got this new emerging discourse about some direct brain practicalities. Smoking, high blood pressure, high cholesterol. Midlife smoking is a strong factor. But in the research, it wasn't clear, I read it that many times, it wasn't clear if any of the studies looked at vape versus cigarette smoking. So that will be an interesting piece of research when it comes out. We know smoking increases your risk, but would vaping carry the same risk? We do know actually that vaping is having a big effect on lung health, more so than what's thought. It was considered a healthy option to cigarettes, but there's a growing body of research talking about actually vaping is still causing a lot of damage. So my guess is here, it will still have a very strong effect. So vaping is not safe. It's still got its own health implications. High and prolonged alcohol intake. So essentially drinking more than 21 units would increase your risk. And if you didn't know what a unit was, I've put some examples there just to give you a bit of a guide. And also, of course, prolonged and excessive alcohol intake can affect thiamine levels. And if you have a depletion in thiamine levels, which is your vitamin B1, we can have a condition called Wernicke's encephalopathy. And if not managed by appropriate vitamin B1 thiamine, it can develop into Korsakoff psychosis and Korsakoff dementia. So alcohol is a big factor. Uncorrected vision loss. Here we are. This is the new 2. So number 13, uncorrected vision loss, new for 2024. So we know that cataracts and diabetic retinopathy appear to be linked. Glaucoma, interestingly, doesn't seem to be. And the element here is, it's not about having the vision loss. It's about not doing anything with any correcting aids or adaptations you've got. So if you wear glasses, but you're not wearing your glasses, you're not correcting it, you're at high risk. Similar to hearing. If you have a hearing challenge, but you're not wearing your hearing aids, it increases your risk. So it's uncorrected vision loss, not vision loss itself. Really important to think about that. So not wearing your prescription glasses or contact lenses, if short or long-sighted, the evidence is showing is starting to increase your risk. So those of you with little children and young ones at home, etc., who have just been given glasses, oh, I don't want to wear those. Encourage them to do so, because the more they don't wear it, the more at risk they may well be in the future. So developing the idea that it's okay to wear glasses, it's okay to wear hearing aids, so people don't feel embarrassed by wearing them, we're actually helping them in the long run. So that's one of the new factors. And the last new factor is high cholesterol, in particularly LDL. So high cholesterol, as we age, is a known thing. It's a type of fat in our blood. And there are two main types, HDL and LDL. HDL is good, LDL is bad. And normally when you get your cholesterol test, it will say both of these together, this is what you've got. From a dementia risk factor perspective, it's really important to say, but which one of those are LDL? Are my LDLs high? Because that's what we need to lower, particularly if you're getting regular periods of high LDL in midlife, then you're at increased risk. So those are the 14 risk factors. Anything else? And I've just put a few bits here. What about sleep? So these aren't the 14 risk factors in that study. It's just bringing on some other discussion points I want you to think about. There's limited research. More research is needed. Some discussion is growing, and more research is coming out. Interestingly, what about shift workers or people who work nights? Are they at greater risk? The evidence talks about a short sleep span suggesting this, but studies are still being carried out. Another risk factor, diet. You may have heard about the Mediterranean diet. Cut back on dairy and meats, etc., and fresh fruit, fresh veg, fish, oily fish, omega-3s, etc. So we know that's gathering momentum. It's just sometimes the quality of the research, we can't be as conclusive, which is probably why it wasn't in the original report. But it's definitely something to be thinking about because it's definitely indicative. So some of the non-modifiable ones then. So these are things that you can't control. So aging, we know as you age, you're at greater risk. But what we are finding is the age-specific dementia incidences are actually decreasing. You've got a higher risk, but number of people being affected is decreasing because I think we're managing risk before we get there better. Genetics, some rare dementias are caused purely by genetics. Huntington's disease is one example. Some of these genetics may, not always, but maybe a feature in younger people. And I've currently doing quite a bit of work on childhood dementias, and almost all childhood dementias are caused by genetics, like Niemann-Pick disease and etc. In other cases in adults, we've got this. We've all got we've all got two APOE genes. We get one from the mom and one from the dad. And we've got an APO2, a 3, and a 4. One from each parent. So there's a potential of 6 different combinations. What we do know is if we've got the APOE2, our risk may be reduced. APO3, neither. And APOE4, increased risk. And then if you've got an APOE4, one from your mum, one from your dad, it's like double jeopardy. You've got a further increase. Now, it doesn't mean if you've got two APOE4s, you're going to get dementia. It just means you've got a higher risk. So it's even more important that you start to manage what you can modify. Now, usually none of us know which of the APOE we have, but I'm just putting it up there so you know there is some genetic discussions about risk out there, but it is quite small. Women, and I put cis women, so you were born a woman. We know there's an increased risk, but is that down to social factors rather than just being female? There is a body of evidence looking at the link between menopause and dementia, but that's still growing until it can be conclusive. And ethnicity, but is that again down to lifestyle factors? So moving forward, we've almost finished now. Moving forward, what should we be doing? And that could be the point of coming to this session today. Well, education, including cognitively stimulating activities in early childhood and midlife. But if you have young ones running around, hopefully you can see by putting things in place now, you're actually reducing the risk of dementia in the future. And that doesn't mean a formal education program. It's doing fun stuff with them, taking them to the zoo. And I sometimes go on a walk and say, "Oh, look, what's that flower?" And then I ask her to tell me what it is in Latin. And then she's got to do a sign language for eating food. I'm quite harsh. But what's happening here is there's a whole range of different things being built up in her little brain, which hopefully will be useful for her future. Reduce exposure to harmful noises, hearing aid accessibility, awareness, assessment, treatment of depression. Sometimes I remember when I worked in the care home, and it was quite easy to overlook depression and seeing it as being normative. Well, it's not normative. So if we recognise the signs and symptoms, let's get people assessed and treated appropriately. Head protection for contact sports. Encourage exercise. Reduce or stop smoking. Regular health checks, including BP monitoring, cholesterol checks for LDL especially, and getting the treatment if you need it. Weight management, but don't rely on BMIs. Monitor your alcohol consumption. Social inclusion. Regular, I'm missing an E there, but regular eyesight checks and wearing of glasses. Contact lenses if prescribed. And do what you can, because it may not be easy, to reduce your exposure to air pollution. And something to further research, but still worth considering, get a good night's sleep and eat healthy. So last slide, this is the last one. A final message to take away in one slide, because that's an awful lot of information. So if you had to think about one takeaway message, just look at this slide. We may not be able to prevent dementia, but we can reduce the risk by increasing our cognitive reserve, managing our cardiovascular health, looking after our senses, and that includes wearing glasses or hearing aids if you need them. Be active, but also keep safe when playing sport. Regular eyesight and hearing checks and use of prescribing aids. A little bit like looking after our senses. And look out for each other to reduce social isolation. And if we do get dementia, by adopting these risk-reducing habits, and for someone with dementia already, and there may be people with dementia diagnosis on the call, if you adapt some of these habits, you may mitigate some of the symptoms that you're facing. Because we do know that we're likely to get it much later and have less years with the condition. No one's researched yet if you have dementia and you put these in place, can you slow down progression? That's not been researched properly yet, but it's not going to hurt giving it a go, and certainly that would be something I would encourage. So as the last exercise I want you to do, if you look at those 1, 2, 3, 4, there's 6 there. I know 2 of them are very similar, looking after our senses and regular eyesight and hearing checks. So let's call it 5. 5 different things we can do in summary after 14. Can you put in the comments box, which one do you think is something you can take away from today? So which one are you going to put in place, or would you advise someone to put in place? Because sometimes if we tell people to do everything, it becomes overwhelming. So what one thing can you take away from those 5? Just pop it in the box. I'll give you just a few seconds. And don't worry about spelling. I'm sure Maggie won't mind about the spelling. If it's Maggie, I don't know who's doing it. Might be Maggie. Okay. Hopefully you've all done that now. Keep typing if not. But sadly, I won't be there with you on the day, but my wonderful colleagues from Dementia UK will be. And I hope you've enjoyed this session and you've come away with at least one takeaway message of something you may do a little bit differently to reduce your risk. And for those of you active in teaching others, then I would, and health promotion things, I would suggest you look at that work by Livingston. Download it. Don't press print till you've counted how many pages you've got. Have a look at the research there and see what you can start implementing into local policy, if you're doing policy, or training plans, or health promotion exercises, etc. And if you've got little kids, start doing some fun stuff with them now, because every time you stimulate their little minds, you're helping them reduce their risk of dementia. So it's a lovely thing to be doing. And I would suggest teaching them sign language or a different language or speaking Latin, because that's what I do, and that's a bit fun. Okay, thank you all very much. It's been a real pleasure. Sorry I won't be there, but I'm sure you will have a great time with my colleagues. Okay, thank you very much.